Good afternoon and welcome. My name is Adrienne Griffin, and I am the host for today's session. I am the Executive Director of Maternal Mental Health Leadership Alliance. We are a small nonprofit focused on national policy around maternal mental health. And together with the Department of Health and Human Services, I welcome you to today's event, highlighting innovative programs to prevent perinatal mood disorders. Next slide, please. Today's event is designed to highlight 3 innovative programs and to provide participants with information about how to implement these programs. The first hour will be a plenary session featuring representatives from various branches of our federal government and state government, and then providing a brief overview of the 3 programs. And then the second hour will have 3 concurrent sessions or breakout rooms, so you can learn more about each particular program. Next slide, please. Some brief guidelines for today's session. Like a webinar format, only the presenters can be seen and heard. Participants are on mute and will have your cameras off. Questions will be handled in the breakout rooms via the chat function. And we have technology on staff today if you need any assistance. Recordings and slides will be available on MMHLA's website following the event. So keep an eye out for a follow-up email when those are ready. Our first guest speaker today is Representative Nanette Diaz-Barragán, representing the great state of California in the United States House of Representatives. Representative Barragán is the youngest of 11 children born to immigrants from Mexico. She has long been a champion for comprehensive and affordable health care, and she is the lead on the Triumph for New Moms Act, which is led by one of our sister organizations, 2020 Mom. Triumph would provide a national task force and strategy for maternal mental health. Please welcome Representative Barragán.
Thank you so much for that introduction. I want to say thank you to all the amazing advocates, policy experts, and federal staff here with us today. My name is Congressmember Nanette Barragán, and I represent California's 44th District in South Los Angeles. It is my pleasure to welcome you to today's summit, highlighting innovative maternal mental health prevention programs. President Biden announced a national strategy to address our national mental health crisis. And a critical part of this strategy must also address maternal mental health. As everyone here knows all too well, maternal mental health conditions are the most common complications for pregnant and new moms. Yet only 25% of those impacted receive treatment. This is an urgent issue we must address. Now, earlier this month, the Health Resources and Services Administration launched a confidential 24/7 mental health hotline to support moms and their families. This is a critically important step, but we must also promote better pathways to programs that prevent maternal mental health conditions before they reach a crisis point. This is why I was so excited that the Energy and Commerce Committee voted last week to advance a comprehensive mental health package that included my bill, the Triumph for New Moms Act. This bill would create a national strategy to address maternal mental health and substance use disorders impacting new mothers and integrate maternal mental health into existing maternal and mental health programs on the federal level. It would also create a task force on maternal mental health to improve our federal response to this urgent issue. It enshrines Congress's commitment to addressing maternal mental health, and I look forward to the work we have ahead of us. Thank you again for including me at this year's Prevention Summit, and thank you to the Maternal Mental Health Action Alliance and HHS for gathering everyone here today. Back to you, Adrienne.
Thank you so much, Representative Barragán, for your leadership, for introducing this important bill, and for your service to our nation as serving in Congress.
Thank you.
Our next speaker is Rachel Pryor, who is Counselor for Health Policy for the Secretary of Health and Human Services, where she oversees Medicaid, CHIP, and substance abuse and mental health services programs. Ms. Pryor was previously the Deputy Director of Virginia Medicaid, and she has over a decade of experience on Capitol Hill and in the executive branch working on healthcare policy. Ms. Pryor, welcome to today's session, and thank you for sharing information about the Biden-Harris mental health strategy and the National Mental Health Score.
Thank you so much for having me. I greatly appreciate being here. And I'm going to have to ask for your patience. I was so excited to speak with you all today. And this is an incredible group of individuals that we have here on the line. I am losing my voice. So I am going to speak up and speak out as much as I possibly can. This is a topic of huge importance. And it's really an honor and a privilege to have the opportunity to speak with you all. I do believe, and I think a lot of us that are here from the federal government believe this, that we are at a very special moment in time. And it's a moment where I think our strong hope in the Biden-Harris administration is that we can stand together and do something real, candidly, for the millions of folks that are out there now more than ever with COVID, suffering without access to the support they need for their mental health and wellness. And nowhere, candidly, is this more evident with our birthing parents and our new parents. Being a parent, and I am one, it is a time of great joy. It is also a time of great stress, from pregnancy to postpartum. And we have got to do a better job as a country of supporting our moms and getting them access to the services that they need. And I think, this session will talk about some of that. But what I want to talk with you about is how I'm hopeful that we can move the ball forward via the president's strategy. As folks know, President Biden in the State of the Union announced a three-pronged strategy, connecting folks to the care they need, creating and building the full continuum, integrating the full continuum into our communities and into healthcare, and building the capacity of our workforce with the workforce we have and the workforce that we need to develop. All of those three prongs are critical to coverage of the services that new parents need when they're struggling both pre-birth and postpartum. Secretary Becerra is uniquely passionate about this issue. I will say he has picked up this initiative with a vengeance. He is currently traveling around our country. He's announced a nationwide mental health tour. Many of our HHS leaders are joining him on that tour, including our next speaker, Administrator of the Health Resources and Services Administration, Carol Johnson. And so we are very excited to hit the ground running, to be on the ground, hearing what we need to do. In HHS, when Secretary Becerra came in, two of his big priorities out of the 5 that he set forth for the department were behavioral health and maternal health. So that fits pretty nicely into what we're talking about here today. I want to ask for the folks on the line that are listening to our session, I want to put a call out to you that if you have something you do believe that we should be aware of, if you have a model or an initiative we should see. Everywhere we go, Secretary Becerra is focusing on mental health. Even if he's going out on a trip for something else, he wants to focus on mental health. So please be in touch with our team. It's really an opportunity for us to learn from you and you to hear more about what we are trying to accomplish. We got to keep the drumbeat going, keep the echo going here so that we can create some real change on Capitol Hill. We are very excited with what's come out of the Energy and Commerce Committee. We need to keep things moving. So we are asking for your help, your support. We're hoping to learn from you. We're hoping to advance the ball. I think folks know that our parents have waited far too long for this moment. And we are hopeful to leverage this moment for all that we can. So thank you again for having me, Adrian. I'm going to turn it back over to you. I hope that people could understand my voice, and really appreciative of the opportunity to be here with you all today. Thank you so much.
Oh, thank you, Rachel. We're so glad that you were able to join us. I know you haven't been feeling well. We really appreciate your showing up today. And we'd love to share information about how people can get in touch with your office or with your staff if they have models that they'd like to share. So if you can send that information to us, we will make sure to send it out in follow-up emails.
Absolutely.
Awesome. Thank you so much. Really wonderful to have you with us. Next up, it is my great privilege to introduce HRSA Administrator Carol Johnson. Administrator Johnson previously served on the White House COVID-19 response team and on the Domestic Policy Council. She also is commissioner of the New Jersey Department of Human Services, and she has spent many years on Capitol Hill as a health staff member for committees in both the House and the Senate. Administrator Johnson has helped expand Medicaid coverage for mental health and substance use disorder and has created new Medicaid benefits to improve maternal health outcomes. So with Administrator Johnson, we have a real champion for maternal health. Thank you and welcome, Administrator Johnson.
Oh, thank you so much, Adrian. And thank you to the Alliance for your leadership and for organizing today's event, to Representative Berrigan for your leadership and for really demonstrating leadership on the Hill on this important issue. And to my colleague, Rachel Pryor, this is but a testament to her commitment to these issues. I imagine if she had no voice, she would still have been here today holding up signs, trying to tell you how strongly she feels about these issues and how hard she and Secretary Becerra are working to address maternal mental health issues. And thank you also to all of you on the line today. I know that this has been a years-long fight for so many of you, and you have been in this work for a very long time trying to address this critically important area. And as Rachel said, we really do think it's a pivot point. It is a moment where the president has identified mental health needs as a key priority for all of us across the administration. The secretary has challenged us as agency leaders to lean in and pull all levers to address these critical issues. At the same time, we are getting the same charge when it comes to maternal health. So as Rachel said, really the convergence of our priority work on maternal health issues and on mental health issues make this a uniquely critical time and opportunity for us to do all that we possibly can to support birthing parents and new parents. As folks mentioned, I'm Carol Johnson. I'm the administrator of the Health Resources and Services Administration. We think of ourselves as sort of the equity agency, and HHS is really focused on delivering healthcare services in historically underserved communities, in under-resourced communities, in rural areas. We run the Community Health Center program that provides primary care services, including prenatal services, in communities across the country, serving almost 30 million people. We are the Ryan White HIV program that serves another 500,000 people. We are the agency that supports rural health clinics across the country, but we also are the Title V maternal and child health programs. We run the block grant that funds states' maternal and child health services. And through that work, we touch almost every child born in the country, newborn screening, a host of services, that early intervention services, as well as perinatal services. And so we are uniquely positioned, we think, to be at the front lines of this battle, because in addition to all of that work, we also are the federal agency that funds, that receives discretionary appropriation resources from Congress to support growing the workforce. And increasingly, those resources are focused on growing the behavioral health workforce. And so we have a real opportunity here to think about both the policy interventions, the way we can fund and support state interventions, and the way that we are building out the healthcare workforce. And so as Representative Berrigan mentioned earlier, we just recently launched on Mother's Day the National Maternal Mental Health Hotline, which is 833-9-HELP-FOR-MOMS. HELP4MOMS, which is a 24/7 confidential access line to help provide the opportunity for pregnant individuals and for new mothers to get direct access to trained resources to be able to help address mental health challenges like depression and anxiety, to help ensure that people know how to get connected to help in their communities. So we are excited to get that up and running. We think we have commitments in the president's budget to continue to grow the capacity of that line and make sure that it is as strong as possible a resource to communities everywhere. At the same time, we also have the opportunity, and an opportunity that has grown with the president's commitment through the American Rescue Plan, to support a program that has a very long title called Screening and Treatment for Maternal Depression and Related Behavioral Health Disorders. And so while it has a very long title, it has a very simple concept, which is that we need to be working to ensure that we're training maternal health providers in identifying mental health conditions and being able to ensure that they can support their patients who have mental health conditions conditions. And that means helping maternal health providers with the best supports possible, including training, but not just leaving maternal health providers then to sort of figure it out for themselves. What we've created through this program are access to teleconsultation services for OBGYNs and certified nurse midwives and others to be able to have direct access in real time to perinatal psychiatrists, licensed clinical social workers, other team support to be able to help them address the needs of their patients. And not necessarily, we have terrific anecdotes about this program, about how it has been able to allow OBGYNs and others to not have to refer someone weeks later to and hours away to a mental health provider, but being able to bring that support real time into maternal health providers' offices. So we look forward to continuing to grow that program. We think it is part and parcel of the way we're going to continue to do our work here to contribute to the overall efforts that everyone on this line has been working towards. And then finally, I'll just mention that the president's budget, as part of his significant commitment and the secretary's prioritization of really working on behavioral health issues, there is a significant investment proposed in the fiscal year 23 budget for us to grow the behavioral health workforce. And we think about that not just as training more mental health providers, but also training the critical community connectors like community health workers, like doulas, like peer supports, like people with lived experience to be able to engage people in care. You all know this better than I do, that that's a critical front door, getting people into care and then helping to retain people in care is so often contingent on really having community-based supports that reflect the community that people live, that are trusted messengers, that can help bring people into mental health services. So we're excited about doing this work with you going forward. We are taking up the president and secretary's charge, and we look forward to your partnership in the days and weeks ahead. Back to you, Adrienne.
Thank you so much, Administrator Johnson. We really appreciate your sharing the information about those programs with us, and you really appreciate the administration's emphasis on maternal mental health and really recognizing that it is so important. Moms, we all have moms. Moms are the heart and soul of the family. And if the mother's not doing well, then the family's not going to do well. So again, thank you for your time and thank you for your support.
Thank you.
It is a great honor and privilege to introduce our guest speaker, who I'm delighted to call a friend and colleague. Jamie Delcito represents the 4th Essex District in the Massachusetts General Assembly. She is also the founder of Maternal Mental Health Leadership Alliance and serves as our honorary board chair. Jamie has been a fierce advocate for maternal mental health. She successfully led a grassroots effort in 2015 and 16 to help pass the Bringing Postpartum Depression Out of the Shadows Act, which provided the first federal legislation and funding to address maternal mental health. So please give a warm welcome to Jamie Delcito, who will provide a brief overview of perinatal mental health disorders. Some people have been referring to them on our presentation so far today as maternal mental health disorders. There's many, many names, but Jamie's going to give us a quick walkthrough so that we're all on the same page. So welcome, Jamie.
Hats off to my fierce leader, executive director, Adrienne Griffin, and colleague, friend, and someone whom I met years ago prior to being in the privileged space of being a representative of my hometown and 6 communities here in what I believe to be the best place in the world, the Commonwealth of Massachusetts. And that space and time for me, I'd say about 8 years ago, was that of a mom suffering from debilitating postpartum mental health conditions and not being able to find adequate support. And so I look at this screen of amazing advocates and doctors and moms and legislators and administrators and everyone here, just to say it truly takes all of us working together. And here we are talking about federal programs, and I'm so blessed to have this space to talk about what I went through personally and why it matters to bring it to the policy space. So we'll go to that next slide, please. perinatal mental health disorders, maternal mental health disorders, behavioral health issues, exactly what we were talking about. It's a range of descriptors, and it's truly not just postpartum. It's not just depression. It seems to be a perfect storm. When we're talking about perinatal mental health, we are talking about the pregnancy piece all the way through to that first year. In perhaps we'll have another conversation of extending that timeline at another place in time. But this timeline encompasses a lot of behavioral health disorders, depression, bipolar. My personal manifestations were anxiety, obsessive compulsive disorder, post-traumatic stress. There's a lot of comorbidities with substance use disorders. I want to say hats off to Congresswoman Nanette Barragán. Thank you so much for addressing this. I'd also like to say, in looping back to what Adrian stated, in 2016, we had a fierce champion named Catherine Clark, who also is a state representative in the Massachusetts state legislature, went on to be in the state Senate in Massachusetts, and then subsequently took the place of former Representative Ed Markey. She heralded and championed our postpartum legislation then, and it's another piece of legislation we're working with her is H7073 for those policy folks out there. I'd like to say hats off to Kirsten Gillibrand, who also continues to be a partner in this space. That's Senate Bill 3824. So when we're taking a look at this little box, going back to what we're speaking about and how it intersects with policy, it's all of these behavioral health issues that can manifest during pregnancy and post-pregnancy. Next slide, please. We've said it before, I'm going to say it again. They're the number one complication of pregnancy and childbirth. Hats off to the Biden-Harris administration, who also specifically stated this in the FY23, and I also believe FY22 budget. You know what's the most incredibly hopeful part about this? They're temporary and they're treatable. And I say that standing or sitting here rather before you on Zoom today to say that where I was 8 years ago to where I am today is night and day. I needed support. I needed someone who understood what this was and needed to understand that there was light at the end of the tunnel. And that is absolutely true. No one is alone in this space. And I'm so thankful for the maternal mental health hotline that we have. I think it's phenomenal. Someone can answer that line. And I thank HRSA and HHS and the administration for working with us on that. This illness affects up to 1 in 5 pregnant or postpartum people. But let us also just highlight the fact 1 in 3. And this is socioeconomic. There's a whole host of other issues that go into this. We see this with our veterans population. We see that with our spouses of serving. There's a lot to boil down in that. But the takeaway is it's incredibly common. You see this big turquoise box here saying 75% of those who experience symptoms go untreated. Untreated perinatal mental health conditions can have long-term effect on the family, on the baby, on society, on mothers. It is incumbent upon us as a society to take care of our most vulnerable, and that is women, that is birthing people, and those are and our babies. This is easy, folks. This is low-hanging fruit, and that's why we're talking about this, because again, there are ways we're going to talk about how to prevent this, and that's the exciting part about today. My other favorite part of this, when folks want to talk dollars, guess what? Drum roll, please. $14 billion per a Mathematica study on what this looks like for not treating perinatal mental health disorders. And I'll also say readmittance based on a study done. It was New York, Chicago, and Florida. Highest readmittance for postpartum individuals were psychiatric readmittance. We have an ability to decrease this and take care of our families. Next slide. We as those of us in this space were so not thankful. That's not the right word. We were not surprised, rather, to find out that the intersection of maternal mental health intersected with our escalating maternal mortality rates. And we found that there were issues around socioeconomics and racial inequities. Very obvious. We have the facts, and we're out there heralding this issue right now. I'd like to say thank you to the Black Maternal Health Caucus, whom we work with all the time to make sure that we are representing those who need the most support. And those are individuals who are underrepresented and are suffering the highest impact. And suicidality and substance use and those comorbidities, we have the abilities to take care of this crisis. And I think the last slide, please. Okay. This right here gives me anxiety looking at it, and I'm not even nursing. I don't have a baby anymore. I'm not feeding. It's coronavirus and it's formula, and we are dedicated to working on those issues with our partners in the federal government. We don't need any more stress. And our last slide, I believe. Why should we care? It's the most common complication. Temporary and treatable, suicide and overdose leading cause of death. What do we find with our maternal mortality boards? 100% of this is preventable. I believe that was it, Adrian. You may have some additional facts and figures. I want to thank this incredible group here today, and would be more than happy to speak with anybody on these issues. And I thank you for the opportunity. And I am blessed to be here before you today to speak about this issue. Thank you to all.
Thank you, Jamie, for shedding some light on a little bit of the details of these illnesses. We know that they can be devastating, but as you said, the good news, most often perinatal mental health issues are temporary and treatable. And so we're going to pivot now to find out what's being done to support new mothers and their families. So it's a delight to introduce Dawn Levinson, who is the go-to person within Health and Human Services for perinatal mental health. Dawn is the Deputy Director of Division of Healthy Start and Perinatal Services within the Maternal and Child Health Bureau within HRSA. Dawn, thank you for joining us today, and thank you for your continued work on behalf of MCHB and HRSA in implementing the important programs that you're going to be speaking about. So please take it away.
Adrian, thank you so much. Thank you for the kind introduction. Hopefully folks can hear me. Again, I'm Dawn Levinson in HRSA's Maternal and Child Health Bureau. I'm, in addition to the Deputy Director for the Division of Healthy Start and Perinatal Services, also the Behavioral Health Lead within MCHB. So I'm very pleased to be sharing with you today our key investments in supporting maternal behavioral health. And I hope that you walk away from the brief remarks here with some knowledge of some MCHB resources that can support your work in promoting maternal behavioral health, whether you work at the national, state, or community-based level. Next slide, please. So MCHB's programs fundamentally promote mental health and well-being for maternal and child populations across the lifespan. And our work supports the principle that there is no health without mental health. MCHB recently launched a new strategic plan that will guide our work over the next 10 to 15 years. That plan sets out 4 goals that support our mission to improve the health and well-being of our nation's mothers, children, and families. That's access, equity, capacity, and impact. The first goal is access. Assuring access to high quality and equitable services has always been central to our mission. We strengthen access to behavioral health prevention and treatment by linking women and families to treatment and supports through screening, referral, direct service, and telehealth, providing patient-centered, culturally and linguistically appropriate and community-based services that address social and structural determinants of health, and strengthening state and community-based comprehensive systems of care for MCH populations. For example, states have used their Title V MCH Services Block Grant to support access to behavioral health care based on the priorities that they identify. States have used block grant funds to lead trainings to promote screening and referral for mental and substance use disorders among maternity care providers. They used funds to implement QI projects with providers, to coordinate across state agencies and providers, to implement culturally appropriate peer support services for high-risk pregnant women, and more activities. The next goal is equity. We are amplifying our efforts to advance health equity in all of our programs. To address health inequities, among other actions, we're expanding support for the programs that we know make a difference. For example, increasing community-based doulas in Healthy Start communities, where the infant mortality rate is 1.5 times the national average. By working with women during pregnancy and after giving birth, including screening for depression and interpersonal violence, and linking to services, Healthy Start helps reduce racial and ethnic disparities in infant death and severe maternal illness. The third goal is capacity. That includes expanding training opportunities and increasing the diversity of professionals and community-based workers. And I'll expand on 2 of those programs in the next couple of slides. Our fourth goal is impact, which comes from communicating our work to the field in forums like this one, partnering with key stakeholders, and consistently monitoring our performance data so that we can continue to improve. Given that our time is short, I will quickly highlight 3 investments in the perinatal behavioral health space more closely. Next slide, please. So this slide actually illustrates something that we heard Administrator Johnson speak to about the screening and treatment for maternal depression and related behavioral disorders. And you can see the 7 states there. So if you are a primary care provider serving perinatal women in one of these 7 states listed here, this service is for you, providing provider training, real-time psychiatric consultation, and care coordination support. Next slide, please. Also, to improve capacity through the Alliance for Innovation on Maternal Health, or AIM, MCHB supports the development and uptake of maternal safety bundles in U.S. hospitals and birthing facilities to reduce preventable severe maternal illness and deaths. Safety bundles are sets of evidence-based practices. In 2021, AIM released a new safety bundle called Care for Pregnant and Postpartum People with Substance Use Disorder. This bundle guides providers to support people experiencing substance use disorder to optimize patient and family health and prevent related severe maternal morbidity and mortality, including overdose. To download this safety bundle or any other for use in your hospital or birthing facility, please go to safehealthcareforeverywoman.org/AIM. Next slide, please. So you've already heard great excitement about the new National Maternal Mental Health Hotline this year that HRSA launched for Mother's Day. And I want to acknowledge that many of you participating today have been very instrumental policy advocates in helping to make this critical service a reality for new moms. So as you've heard, the hotline provides 24/7 free confidential support, resources, and referrals to any pregnant and postpartum moms facing mental health challenges or their partners and providers. Professional counselors staff the hotline, providing support in English and in Spanish, along with translation services in up to 60 languages. HRSA contracts with Postpartum Support International, or PSI, a leader in perinatal mental health support, to operate and maintain the hotline. So you can see on the slide, to reach the hotline, please call or text 1-833-9-HELP for moms. Okay, next slide, please. Okay, and so this is my contact information along with MCHB's webpage on behavioral health. I hope that as you all participate in today's Prevention Summit, that you can join MCHB in our critical efforts to improve access, equity, capacity, and impact. We all have a role to play in the well-being of mothers and infants, and I hope that knowledge of some of these resources will help you further your efforts. And please connect with HRSA on one of our 4 social media platforms. Thank you so much.
Thank you, Dawn. You are our hero. You are our go-to person. You are our champion within HRSA, and we are so grateful for all the work that you've done in supporting those programs. So thank you. Now we're going to take a pivot and we're going to turn to our 3 prevention programs. I'm really thrilled to have the leadership from each of these programs with us. Each one of them is going to do about a 7 or 8 minute presentation. And then in the second hour, we'll have the opportunity to do a deep dive where we'll have breakout rooms where you can go and listen to more information about each one of these programs. So up first, we have the Mothers and Babies program. Please welcome Dr. Mimi Lee from George Washington University and Dr. Darius Tandon from Northwestern University who will give us an overview of mothers and babies. Thank you for being with us today.
Thank you again, Adrienne. Darius and I are thrilled to be a part of this very honored, privileged group. So please welcome. Next slide, please. I'm going to start us off on talking about the Mothers and Babies program, and then Darius will take over. Next slide, please. I want to start and talk a bit about the history and development of the Mothers and Babies program. And I know that Ricardo Munoz is actually on the line with us. So shout out to Ricardo. This work really started in the late 90s as part of the Latino mental health research program at San Francisco General Hospital, part of the UCSF system. I was a lowly intern and postdoctoral fellow working with Ricardo as my mentor, and he has been one of the pioneers of leading the efforts to prevent depression in primary care patients, which was what was happening at the time. And at that time, he really wanted to pivot to identifying another population that could warrant prevention efforts. And at that time, there wasn't any efforts at all towards perinatal women. And so collectively together, we adapted this work for low-income perinatal Latinas in the OB setting at San Francisco General Hospital, which is very much in the barrios of San Francisco General, serving low-income Latinas. Next slide, please. So the goal of the Mothers and Babies program is really to teach perinatal people who are at risk for developing clinical depression. And so the goal is to reduce the onset of major depressive episodes by teaching perinatal individuals mood regulation skills, as well as education regarding parenting and child development during this very critical period of time. So initially it was group-based, as you can see here. Next slide, please. The main theoretical framework is cognitive behavioral, in which we are looking at how thoughts and behaviors can affect one's mood. And one of the adaptations that we made for low-income populations is to really recognize this within every person's individual reality, and that recognizing that our internal reality, which is what is in our minds, as well as what is in our external reality, who are the people who are in our lives, the communities, the neighborhoods that we live in which we may not have as much control over. And so the goal of this program is really to figure out and help perinatal individuals manage the reality in the healthiest way possible, whether it's intervening with the internal reality or the external reality in terms of helping us to modify our mood. And being able to do this, integrating also attachment theory in order to promote parent and infant bonding using both cognitive behavioral strategies. Next slide, please. So in our early work, we were able to do a pilot study in San Francisco, focusing on a 12-week group-based intervention that was done in prenatal care in a hospital setting. Over time then, so there were 3 randomized controlled trials that were done that very much laid the groundwork for demonstrating the evidence base of the Mothers and Babies course. So as I mentioned, the first one was in San Francisco. The second one was in Washington, D.C., focusing on Central American population. And this work actually done was with funding from MCHB, which we're very grateful for. And the third work is the work that has been done by Darius Tandon and his team initially at Johns Hopkins, focusing on pregnant and postpartum African-American mothers in home visiting programs. So through OB settings, through the federally qualified health centers, work in DC as well as in Baltimore and home visiting. These studies very much laid the groundwork and evidence that was demonstrated as part of the US Preventive Services Task Force. So I will hand it over to Darius then next.
Thanks, Mimi. And just echoing how delighted I am to be here. Wanted to also acknowledge Ricardo, but also acknowledge members of our research team at Northwestern, who I know many have joined, and they really are responsible for much of the work that I'm going to be sharing over the next couple minutes. So Mimi talked about the U.S. Preventive Services Task Force report, and what I'm going to share is some work that we are currently engaged in and planning to do that is really moving beyond that report. So one of the things that we have really been focusing on is looking at impact of the intervention in different ways, including a large study funded by the Robert Wood Johnson Foundation to examine the effectiveness of the one-on-one modality. So you heard Mimi refer to mothers and babies initially developed as a group-based modality. A lot of the work that our team has done has focused on integrating mothers and babies into the context of home visiting, where the one-on-one modality really is a good fit. So that is a study that we have just completed. We are in the midst of doing a study funded by NICHD, looking at the longer term impact of the intervention when delivered prenatally, looking at outcomes such as responsive parenting, parent-child attachment, young child self-regulation. We know maternal depression has a 2-generation impact, and we believe that this study is really going to allow us to look at the impact on not just maternal mental health, but also some of these parenting and young child outcomes that are critically important. We also think that there are issues of equity that are really important to bring out in terms of trying to get mothers and babies to as many perinatal individuals as possible. So we really are doing a lot of work focusing on both expanding the reach of the intervention and engagement of providers and families with the intervention. So consider this a teaser. If you come to the deep dive in the second hour, we will give you more details on some of this work. But just to highlight some of the things that we're currently engaged in: adaptations for tribal and indigenous families, adaptations for low literacy individuals using materials that are more visual instead of word-based, and adaptations for sexual and gender minorities. We're also looking at new modalities for delivering the intervention. So beyond the group-based and one-on-one modality, our colleague Lynn Barrera at Palo Alto University has developed an online version of Mothers and Babies, EMB. And we're hopefully going to be starting a study soon looking at the group modality being delivered in a virtual format. Administrator Johnson mentioned reliance on not just mental health professionals, but other individuals to lead interventions. And we recently completed a study that was looking at exactly that, the idea of task shifting delivery of the intervention away from mental health clinicians to lay professionals. And these were lay home visitors that were working across 7 states in the Midwest. Next slide, please. We're also looking at ways in which mothers and babies may be connected and can help address other health areas. We're just starting a project right now integrating mothers and babies as a package of intervention content to improve cardiovascular health of pregnant individuals and their offspring. That's funded by the National Heart, Lung, and Blood Institute. And Mimi is doing amazing international work integrating mothers and babies as part of early childhood development, prevention of mother-to-child transmission for HIV-positive rural populations in Africa. And finally, I want to highlight a really interesting and impactful innovation that we've been working on for the last couple of years in developing a fathers and babies curriculum. We were always asked, well, what about the fathers? And thankfully, a few years ago, we were able to receive funding to develop and pilot test fathers and babies intervention that has been delivered concurrently with mothers and babies. And we're now refining it to be delivered as a freestanding intervention. And then our final slide is just our contact information. And we really are looking forward to engaging with you in the deep dive in the next hour. Thank you very much.
Oh, thank you so much, Mimi and Darius, for that great presentation. It's so terrific to see the iterations, the transformation of mothers and babies from, the classroom setting to the one-on-one setting and addressing fathers. So great work. Keep up the great work. I can't wait to see, learn more in the breakout session. Okay, so our second featured program is called PrEP, which stands for Practical Resources for Effective Postpartum Parenting. PrEP was co-developed by Dr. Catherine Monk and Dr. Elizabeth Werner at Columbia University in New York. So Dr. Monk will lead the brief overview, and then Dr. Werner will be doing the deep dive session. So Catherine, please take it away.
Great, thank you. Next slide, please. And I just want to emphasize, I'm so pleased to be here and really excited about the conversation. So yes, PrEP, as you've heard, is practical resources for effective postpartum parenting. And we view this as a mother-infant diatic treatment to prevent postpartum depression. Next slide, please. So to give you a brief overview, this is a brief 5-session intervention. And the duration is also rather brief. So we're starting, as you can see, at 28 to 32 gestational weeks and then going out to 6 weeks postpartum. And it is for those who are at risk of postpartum depression based on high levels of stress or depressive symptoms, really experiencing all the social determinants of health and stressors that come with poverty. Next slide, please. So our conceptual model, we think there are 2 unique features. One, that it begins in pregnancy. Now that is less unique for the very important group that is here today. I think we all start in pregnancy somewhat, but for the field out there in terms of thinking about postpartum depression, it doesn't usually start in pregnancy. So our prevention intervention PrEP starts in pregnancy, and we really take a dyadic approach. So to summarize what that means for us, we think about this as an intervention based on the conceptualization of postpartum depression as a potential disorder of the dyad, and one that can be approached through preventative psychological and behavioral changes in the mother that affect her and the child even before birth. Next slide, please. So the rationale for this dyadic approach, and it's really central to our work, this dyadic approach. There's the identification with the parenting role. This has historically been called a primary preoccupation with the baby. That begins in pregnancy. So we really want to leverage that mindset. Where is the pregnant person's mind at? It's so often focused on the baby. And we really want to use that to do our work to have prevention efficacy of postpartum depression. And just to highlight one aspect of why we're taking this dyadic approach is really thinking about how the mother and infant affect each other. One aspect, meaning I'm going to talk for a minute about sleep. So we know that lack of sleep is a risk factor for postpartum depression. And the greater the infant fuss, cry, and poor sleep behavior, that's also associated with the risk for postpartum depression. And in contrast, there are behavioral techniques that are effective in improving infant fuss, cry, and sleep behavior. So if we can leverage those interventions to help the baby sleep, can we also help the mother sleep better? Next slide, please. So there are 3 treatment components to PrEP. One is mindfulness, sleep hygiene, and self-reflection. And the other is psychoeducation and cognitive support, particularly around managing expectations. And the third is behavioral techniques. So we're combining established mindfulness and psychoeducation CBT tools with this dyadic approach so that we're taking the behavioral portion of it. And those are techniques for parenting newborns that are going to help that baby. And we think, and have data to show, also helping the mother. Next slide, please. So we think of this dyad in the perinatal period. Again, the baby's on the mother's mind even before birth, and in the postpartum as mutually influencing each other. So taking our circle here, and let's start with the lower left, I've highlighted the 2 components, the sleep skills and mindfulness. Those are directly going to improve women's sleep and lessen her distress. But then going clockwise, when she's feeling better, she has a more sense of competence and self-efficacy. That's already good for her mood. That may also help her in her parenting to optimize infant behavioral regulation, which then is going to help the baby sleep better and help her sleep better. But we can also start with component 3 on the upper right. These are the specific behavioral skills that we are coaching women on in PrEP. They've been shown to work in other sleep interventions with baby, day-night cues, focal feed, carrying independent of crying. If we can help the mother through these behavioral techniques, get the baby to have more optimized regulation, that's good for the baby, and it's also going to feed back in the other way and help her sleep. Just taking a piece there of how we think mother and baby are co-regulating in this period. And it starts in the mind in pregnancy. And we can teach the tools in pregnancy as well. Next slide, please. So just to really emphasize that we are looking at in the bold the direct effects of the parenting skills and the mindfulness and self-reflection as either parenting skills directly helping infant regulation or the mindfulness and psychoeducation directly helping the mother. But as I've already rather highlighted, we have these indirect effects such as parenting skills, potentially helping maternal sensitivity, which also helps infant regulation. If she is feeling able to use mindfulness tools to feel less distressed, she's going to have more positive attributions about her baby. That too, through parenting, could help infant regulation. And if she's viewing her baby as easier to take care of, her sense of competence and efficacy is going to be higher, which in turn will also improve her mood. Next slide, please. So in addition to this dyadic approach, we think about PrEP as trying to solve many of the access to care problems that exist around mental health that we've just been hearing about earlier today. So for example, there still unfortunately is a lot of shame around endorsing distress in the context of childbearing. So we focus on the maternal and infant roles on the dyad. It's a way to move away from that shame. There is still stigma associated with mental health care, very unfortunate. We use the term coach to move away from that. And our program name PrEP also can really assuage that concern. The logistical challenges of attending added healthcare appointments at a different location, big problem in access to care. Our sessions are timed to be adjunctive with OB prenatal visits and the 6-week postpartum visit. We're doing them via telehealth. There's the potential to incorporate into OB practices in the prenatal care ecosystem, the entire PrEP program, and we can train a variety and have trained a variety of providers and disciplines. There's the disinclination to take medication while pregnant or breastfeeding. We have behavioral and cognitive foci. Next slide, please. So I just want to wrap up with some patient experience. This was Gina. She had a challenging living situation, facing a potential eviction threat. The father of the baby was absent. She's really unsure how to take care of her baby, endorsing a lot of stress. After PrEP, she felt more prepared for motherhood. PrEP helped her manage the stress of caring for a crying baby in a very cramped place. The mindfulness techniques helped her with her ruminations at night. She said, it helped me as a mom and as a person. Next slide, please. Another patient, Lucius, also a difficult living situation, particularly with someone with an addiction problem. She's very young, 20 years old. PrEP helped her to be empowered to make a change in the living situation. She said to become the type of mom she wants to be. She shared the pamphlet, the tools with her mother so they could both be on the same page when caring for the newborn. She said, I really appreciated all the information on the period of purple crying, part of the psychoeducation. I would have freaked out if I didn't know what was coming at 2 weeks postpartum. Next and final slide, please. So we, again, really pleased to be here and excited about this summit. And in our next session, we will go into some efficacy data and take a much closer look at the PrEP intervention. Thank you.
Thank you, Catherine. What a great presentation. And how simple, right? We just focus on sleep. And for many, many years, I answered phone calls and emails and talked with new moms experiencing perinatal mood disorders. And we spent so much time talking about sleep. Sleep is the most important, least expensive, most effective thing that a new parent can do to help with their mood. And so I'm really thrilled to see that you take such a basic, easy concept and really have built a program around that. So thank you for all the work that you do. Okay, so our third and final program today is the ROSE program. ROSE stands for Reach Out, Stay Strong Essentials for Mothers of Newborns. So we're pleased to welcome Dr. Karen Zlotnick of Brown University. She'll give us the overview, and then Dr. Jennifer Johnson will lead the longer session. So Dr. Zlotnick, please, the stage is yours.
Thank you, and thank you for the organizers of this very important summit. Next slide, please. Today we're going to be talking about Reach Out, Stay Strong, Essentials for Moms of Newborn, the ROSE program. Next slide, please. So ROSE is based mostly on interpersonal psychotherapy, which is the frontline treatment for postpartum depression. Next slide, please. Interpersonal therapy targets those risk factors that play a role in the onset of postpartum depression and more importantly, are amenable to change. And these are low levels of social support, isolation, and interpersonal conflict disputes. Next slide, thanks. So Rose is administered individually or in small groups during pregnancy. Rose is presented as a course or support group, so we minimize stigma, and we really try to emphasize that the program is an educational experience. Rose consists of 4 plus minus 90-minute group sessions, or if you do it individually, it's plus minus an hour. And then there's a brief post-delivery session that really functions as sort of reinforcing the themes of Rose and a sort of check-in session. Next slide, please. So Rose can be delivered in so many different prenatal settings that serve prenatal individuals, and Healthy Start programs, doula services, WIC, federally qualified health centers, prenatal clinics. They all can deliver Rose in their setting. And it can be, Rose can be taught by non-mental health professionals. You do not need to have a mental health expertise. So that could be health educators, nurses, midwives, as well as paraprofessionals. In our trials, which I'll briefly touch on, we had health educators and we had paraprofessionals, and even showed that the paraprofessionals in our largest trial could adequately deliver Rose with competence. And then the intervention materials, they very easy to use. We have an educator manual, we have an English and Spanish participant workbook. The workbook, we also have a version that is gender neutral. We have flashcards. We even have slides now for virtual delivery. Next slide, please. So Rose comprises, the 2 core elements is there's the psychoeducational component, where we talk about postpartum depression, postpartum blues. We educate around, survival skills for motherhood, the importance of social support as a buffer against postpartum depression, really emphasize what are the local postpartum resources. And then there's a teaching component. We teach communication skills via role plays, stress management skills, ways to build and enhance your support, your social support. And Rose has a lot of flexible elements. You can do it in a group, individually, as mentioned. You could have in-person visits, home visits, telehealth visits we've found we can do, and we even have some sites who deliver it by phone. Can be any time during pregnancy. You can do the sessions, whatever order you like. Also, what's important is that the sessions actually can be split up, and many agencies do this, into shorter pieces. And so it could be integrated into a centering group, or it could be lumped together. And we've had sites that do 2 sessions, like a marathon Rose at one time. Next slide, please. And this is just an overview of the workbook, so you can kind of see the different components. Next slide, please. So Rose is an evidence-based practice. We've done a series of randomized clinical trials with financially disadvantaged individuals, and we have used a validated diagnostic measure of postpartum depression. In other words, it's not based on sort of symptom measures. We've replicated our positive finding. As I said, we've done it in many different settings and a very sort of both racially and ethnically diverse samples. And the bottom line is Rose prevents half of postpartum depression cases among financially disadvantaged Rose participants. Next slide, please. And so really, the next step for Rose is to disseminate, which we have done we have a website where you can access all the materials, and then to see how well we can implement Rose. Next slide. And we have an implementation trial where we have trained 98 prenatal agencies across the US to implement Rose. And there's actually another trial at the moment implementing Rose at VA centers. And Dr. Jennifer Johnson, who has led the initiative for the implementation study, will be sharing in the breakout session our experiences and of training all these sites, as well as the sites' experiences of delivering Rose. Next slide. So thank you, and there's the link that can take you to all the materials. Thank you.
Oh, thank you so much, Dr. Zlotnick, for that wonderful overview. I'm so impressed by all of the different ways that roses can be delivered. And that's partly why we wanted to host this session today, so that we can see that these are not standalone efforts, that they can be woven into existing opportunities where women are already accessing care. Because the last thing a pregnant woman or a new mother needs is more appointments. So it's really thrilling to see all of the different ways that you have made Rose is so flexible.